Good morning or good afternoon or good evening. I'm Jackie Drew and I'm the president of the International Physical Therapists for Hospice, Palliative Care, Oncology, and HIV/AIDS. And I want to warmly welcome you and our speakers to this session. This is an exceptional session. We have Marianne Dalzell and Janine Hitting, both professors. Marianne's from Canada and Janine is from the Netherlands, and they're going to talk about developing oncology skills. And then Chiwi from Caledonia University in Ireland has had his students do a special project which is leading to this networking session and other networking sessions. And they are Katrina Belarbi, Janie Ann Dean, Jenica Nicole Frederick, Sophia Bolvin, and Elizabeth Anger Khan. So I'm going to step aside and hand this presentation over to my student hosts, and they will be leading us through this session and introducing our speakers. Thank you for coming.
Hi there. Lovely to meet you all. I'd like to introduce myself first. My name is Katrina. I'm a third-year postgraduate pre-registration physio student at Glasgow Caledonian University. I'm a registered nurse myself and I work in paediatric oncology, so doing my postgraduate in physiotherapy. My mum is a two-time cancer survivor, hence my keen interest in oncology and cancer rehabilitation. I would be interested in enhancing the rehabilitation through research and the global sharing of ideas and applying that in to my future career as a physiotherapist. Lovely to meet you all, lovely to be here.
Hi, everyone. My name is Janine Nicole Frederick. I am a second-year student at Glasgow Caledonian in pre-registration of physiotherapy. I'm in my placement year. Graduation is in July. Yay, me. And I was born in the United States, but I've moved to Nassau, Bahamas, where I've lived since I was in the 11th grade. So that's technically where I'm from, I say. Let's see, I had my undergraduate degree in biology and now my master's in physiotherapy. And I have a very soft spot for kids. I'm actually in a pediatric placement right now and it's challenging, but I absolutely love it. And I have an interest in also AIDS and HIV research, typically because I'm coming from the Caribbean and from Nassau, Bahamas. We have the highest prevalence of AIDS within the Caribbean, so that'll be interesting. And also oncology piques my interest, basically anything to do with kids. So I'm so happy to be here and to learn from you guys and to share my knowledge as I progress in this profession. So thank you guys for coming and we'll talk more later.
Hi, I'm Janie. I'm a first-year master's student at Glasgow Caledonian. I'm originally from Belfast in Northern Ireland. My undergraduate degree is in psychology, so I'm really interested to learn about how that impacts in physiotherapy, rehabilitation, in oncology, but also like in just rehabilitation in general. I'm also really looking forward to hearing about some international guidelines and differences in physio treatments all over the world. So that's why this subgroup is so interesting to me, because it will be so many different opinions and so many different treatment sort of standards that we uphold. So I'm really looking forward to this session. So thank you so much.
Hi, I'm Lizzie, and I'm from Penang Island, Malaysia. I'm in my third year in my doctorate of physiotherapy program at Glasgow Caledonian University, and I have a background in sport and exercise science from the University of Exeter in England. I mainly got into it because of my active participation in dance, ballet, and cheerleading. And I'm very honored to be part of this event today, and I'm really eager to learn more about what will be shared about today. Thank you.
And lastly, I'm Sophie. I'm also one of the students from GCU. To introduce myself, I did my undergrad in health sciences in Canada, and now I'm doing my first year of my master's of physiotherapy in Glasgow, Scotland. I do have a particular interest in oncology, but as well, I do think it's extremely important to interact globally as a profession, as I've seen firsthand just as much as you can learn. So I'm super excited to be here, as it is such a great opportunity to learn from these speakers. So now that we've gone through the introductions of the students, we're going to move on to the session. So first, I just want to thank both Marianne as well as Janine for taking the time out of their Saturdays to come to their presentations to help us learn a little bit more about developing oncology rehab. To start, to kind of warm us up for this global event, I think everyone should post in the chat where they're from so we can start to see where everyone is tuning in from. So if you just want to click on your chat button at the top there or wherever it is on your screen and post where you're from, it'd be great to see. I'll start us off. I'm from Canada, like I said. Oh, we got some more Canada, Scotland. Nice. So mostly Canada and Scotland, some UK. Oh, the States, awesome. Cool. So moving on, I'm just going to give us just a quick kind of overview of how this session is going to run. So each speaker is going to present, taking approximately 30 to 45 minutes. And then there'll be a short amount of time after each of the speakers for questions. So we ask that throughout the session, you do keep your mics muted as well as your cameras off. However, during the question and answer period, if you do feel comfortable coming on the mic to ask your questions, just click the raise your hand button and we'll call on you to do so. If you don't feel comfortable doing this, just post your questions in the chat and we'll try to answer it for you. So now that we're done that, I'm going to pass it on to Katrina and she can give you a brief overview of the speakers or an introduction.
Hi there, so I'd like to introduce our first speaker. It's with great pleasure that I introduce Marianne Dalzell, who is currently the Chair of National Education and Clinical Mentorship in the Oncology Division of the Canadian Physiotherapy Association. She was Clinical Director and Research Coordinator for the Rehabilitation and Exercise Oncology Programme from 2006 to 16, HOPE and COPE, Segal Cancer Centre in Montreal, and co-founder of the McGill Cancer Nutrition Rehabilitation Programme, serving as Associate Director from 2002 to 2006. As a clinician with 30 years of experience in the management of complex orthopaedic problems and past faculty lecturer in the School of Physical and Occupational Therapy, McGill, she has coordinated and taught specialised courses in orthopaedics, sports medicine, biophysical modalities and cancer rehabilitation, and continues to teach basic and advanced courses in rehabilitation oncology nationally for the CPA and a progressive series of online courses with BIA Formation, Quebec, and Key Clinical Skills, Ontario. I'll hand it over to you, Marianne. Marianne, beg your pardon.
Thank you very much for the introduction, Katrina. I just sound very old when I listen to that. Anyhow, we'll get a start here. I'm hoping the screen share works. And before beginning, I would really like to, here we go. And I'll just put this on slideshow and you tell me whether or not this is functioning. Are we good? Thank you. So now that the technology is up and running, I'd like to thank Jackie for having approached me to do this session. And thanks to all of you for having the courage to organize an international session as well and do all the technological setup yourselves. I think that this is exciting. We're constantly trying to mentor students within our various universities, but oncology usually takes second place to things like orthopedics and sports medicine, which are much more glamorous in general. So it gives me really great pleasure to be here and to give you an idea of what my career pathway has been, because you would say, how do I get to cancer rehabilitation from orthopedics and sports medicine. I was teaching orthopedics for the better part of 15, 20 years, and then was doing sports medicine alongside that. But in the process of being there and of being quite specialized in ortho and working clinically, I began to get a greater and greater number of referrals from patients who had had cancer, who had had reconstructive surgeries, pediatrics. I was working with some of the orthopedic surgeons at our children's hospital, and I was suddenly getting patients who had had hemipelvectomies and other types of reconstructive surgeries, and I had no idea where to go. I felt as though my clinical skills, as much as they were there within orthopedics and I could apply, so many of my texts were saying, don't touch, this patient has cancer. So that set me on the journey to really learn more about the disease of cancer and to see how I could help these same patients. I'm hoping to impart some of that today. So what is cancer rehabilitation? And it is what we help most patients do with various different disease entities, and that we're trying to maximize the physical, the social, and psychological function within the limits of whatever the disease entity might be. And what we're talking here is cancer. Now, there are differences, however, because most disease entities that we deal with are unifocal, if you wish, or unidimensional. It could be orthopedic, or it could be neuro, or it could be cardio, or it could be CNS. But in this case, cancer covers all of the above, so that it is a much more global sphere of education that we need in order to work and to help maximize physical, social, and psychological function. There's a great deal of education that's needed for us to work with sufficient information in this realm. So why cancer rehab? Well, the key words here are the prevalence, the fact that it is so disabling, the treatments can be very disabling, costly, and there are significant work losses associated with it. So we say why cancer rehab is because cancer has become so prevalent. In fact, cancer, when we look at prevalence, the number of deaths now related to cancer surpasses that's related to cardiovascular disease. And the overall prevalence is very closely approaching that of what we have seen in the past with cardiovascular disease. So this is why suddenly cancer rehabilitation has become a term that we're seeing at minimum being utilized more frequently in oncology. So it is prevalent, it's disabling, the survival rates don't reflect the burden of treatment toxicity and disease, disability associated with treatment of the disease itself, huge projected annual costs, estimated in the US alone to be $157.7 billion in direct costs to the medical system, and not considering the indirect costs to society, which are great as well. Oops, it's not moving forward, sorry. I'm not able to advance the slide. There you go. Okay, so why cancer rehabilitation, again, is because so many of our patients may have been diagnosed with cancer at the time that they have 2 or 3 other comorbidities. The average age for diagnosis of cancer is still, for most cancers, is in the realm of 62 years of age. So those same patients are aging and have potential cardiovascular disease or other neurological concerns and disease entities in association with the treatment that they're now going to be embarking on. So it certainly makes the impact of the disease that much greater. And I think that what I have certainly learned through the years is that self-management only works for those who have not been chronically ill in the past or who may not have as complex a treatment regime. Self-management is difficult. Patients do need this direction. If nothing else, they need education on the part of how they can help themselves and improve their well-being. Elderly are at great risk because of the comorbidities and many social inequities we're seeing related to the follow-up and services provided as well. Return to work is a big preoccupation with us presently. We're hoping to do a national grant application for return to work for our cancer patients. We have an important role to play. And I certainly have realized this over time, how important a role we have to play. Because not only are we there just to support patients through their treatment and improve the costs potentially related to their treatment because they can be better, but we're also improving treatment options. We're improving their performance status, their performance capacity, so that they can at times tolerate greater treatments. We can decrease hospital stay and certainly reduce the treatment-related impairments. So we have been moving towards this knowledge of cancer rehabilitation in Canada, and there was a national initiative in cancer rehabilitation, and the consensus recommendations from that national group of experts were that screening is essential, that is one of the things that's not happening on a consistent basis, and assessment at minimum of patients that are undergoing treatment and become part of cancer care programs. And it has to become an important part of survivorship services. And guidelines, you mentioned guidelines in the introduction, of interest to everyone, are finally in process of being developed internationally, certainly nationally. We have a number of groups working on practice guidelines. And more important, it always appears to be cart before the horse. We need education, and training has to be expanded. And I'll give you an idea of where we are in Canada in a few moments. And we have to identify, of course, the research gaps. So we're in need of all of this education. And again, I'm very happy to be speaking to you who are at the forefront of potential development of this cancer rehabilitation. And as the needs become recognized, there's greater accessibility is needed for the specialized education, which is quite sporadic as it is at present. There are, why is cancer so different? And I would say that of all of the things that I've treated in the past, I mentioned that it's not necessarily that orthopedics is unidimensional. I've worked in many different realms of orthopedics, like reconstructive surgery, sports medicine, sports injuries, sprains and strains and back problems. The difference with cancer is the disease itself. We're applying our skills that we learned in other realms potentially, in all other realms potentially, to this disease of cancer, because the nature of the pathology, the manifestations, the physical manifestations of the disease, the staging and classification, it's all a new language. It's a new area of study for us completely. It's like learning legalese. It's like going into the legal profession or going into the medical profession when we all began. It's a new language that we all need to learn. And the age range, it's again unusual because this is one of the disease entities that doesn't impact just one population like pediatrics, but rather impacts all age ranges of patients. Again, just widening the scope of what needs to be studied. And the effects of treatment can be worse than the disease itself. And we, those of you who've had any experience with cancer realize that many patients are asymptomatic prior to the treatment beginning. The moment that treatment begins, so many other types of dysfunction develop as a result of the treatment itself. Huge impact on the quality of life. So, and the unique characteristics of cancer, as we go speaking about the disease itself, is that we have space-occupying lesions, don't respect normal anatomical boundaries. They're dynamic, they can be changing over time. The treatment cycles are difficult because patients don't receive, they're usually multi-dimensional treatments. It can be chemotherapy, radiotherapy, and surgery that preceded all of the above, and patients are just impacted one after another by these various treatment modalities. So that's a challenge. Degree of pain interference is significant. Muscle loss, metastasis to brain or bone, and unique, without question, impairments and dysfunction. So it is a very wide scope of area. One cannot just take one simple online course and think that you've mastered everything there is to know about cancer rehabilitation. There are residual cardiovascular problems, chemotherapy-induced cardiotoxicity, persistent and debilitating fatigue, particularly for those patients who have had a history of cardiovascular problems prior to the disease itself. And there's residual pain. I've mentioned review of the last 40 years, meta-analysis of multiple articles have shown that pain is still an issue with many patients. One would have thought that in this day and age that there are excellent treatment modalities related to the types of pain that patients with cancer have, but that's not the case. Much of the source of the residual pain is musculoskeletal in nature or neurological. And so that we again have so many treatment modalities that can assist patients to overcome the pain and the residual pain that they're experiencing. And persistent neurological problems. So the CIPN, chemo-induced neuropathies, radiation exposure resulting in chronic fatigue, loss of balance, muscular coordination, brain fog, a significant issue with patients wishing to return to work, and direct peripheral nerve damage can occur as well. So all our colleagues that are working in neurology need to become more engaged within cancer rehabilitation as well. There are so many treatment and research gaps, so not treatment with respect to cancer treatment, but rather our rehab interventions and research gaps when we look at the scope of cancer rehabilitations. And as it is presently, survivorship services, which are existent in most cancer treatment centers, have been largely defined as being psychological support, psychosocial support, and not necessarily physical support. And that has been a battle or an uphill battle that I personally have had to fight at all of the treatment centers that are McGill affiliated, where we were categorized as being psychosocial support. And as a result, we didn't have access necessarily to all of the sufficient information that we needed with respect to the treatments that patients were receiving. Because we're not just an add-on, we're not just something that can help patients after the fact. We should be there from the onset of treatment, and that what we do is very related to the physical changes and the physiological changes associated with patients undergoing treatment. So the data on psychosocial support does not show increased survivorship, whereas that is upcoming in cancer rehabilitation and certainly in exercise intervention has certainly showed improved survivorship. So we need research on comorbidities and cancer prevention, detection and treatment of early and late side effects of treatment, etc. Lots of gaps. What is the status overview presently is cancer rehab has evolved, thankfully, from simple supportive care and palliative care to complex and more targeted rehab interventions to allow this adaptation to daily activities and life roles. And a substantial amount of data suggests that exercise benefits significantly at all stages of disease. And there's quite a bit of, and I can say this research that has been done in exercise has really opened the door in the eyes of oncologists to the potential value of rehabilitation interventions and exercise interventions more specifically. And in doing the exercise screening, we are actually capable of teaching the oncologists, all realms of oncology, that prior to exercise, patients may well need some sort of a rehab intervention in order to allow them to do the prescribed exercise. And I would say that has been the greatest door opener for us. It was easy to enter into various realms in various departments of oncology once that exercise benefit opened the door. And relative role, of course, of the physiatrists, which we have here in Canada, but not in all provinces necessarily, physiotherapists, occupational therapists. So the role, that model really has to be developed as well, multidimensional, multidisciplinary rehab interventions. So what is the status of cancer rehab in Canada? Well, just a while ago, 2013 was the last review that was done by a number of the cancer rehab specialists in Canada, and they identified 20 cancer rehabilitation sites. and 50% located in hospital outpatient departments. But there was a huge variability in the types of services. So in other words, they could call themselves cancer rehabilitation, but in effect, the majority of the interventions were educational. It was pamphlets being handed to patients at the time of diagnosis and or after. Unsupervised exercise in the community. In other words, telling patients exercise is good for you, but no, sorry, we don't have any resources in order to supervise you in your progress. And breast cancer follow-up and lymphedema certainly have been better developed. And I say by and large because the breast cancer patients have been advocated for these services to be developed. By and large, they've been self-advocates. And because of the prevalence of breast cancer, of course, many of the services presently in Canada are really directed almost uniquely towards breast cancer still to this day. There are fewer services for head and neck, hematological, lung, prostate, and GI cancers, which in my experience have almost greater degrees of disability associated with the treatment and the disease itself than some of the breast cancer patients that we see. And there's a wide variety still here in Canada of professionals coordinating and implementing programs. It's still clinically undervalued here in Canada. We're doing our best to educate. Access remains poor, certainly in rural areas, and care can be fragmented. So if you're in a specialized cancer center, access can be reasonable, but if not, access can be quite poor and fragmented. Actually, this has been one of the benefits of online education and patient interventions, as we've actually been able to enlarge our network of patients that are served by cancer rehabilitation. So there's been an inequality of access, many needs not identified because the screening's not systematic. And that is one of the pushes that we made as soon as we implemented the program within McGill, is that systematic screening somehow within the different departments of oncology, not just one department. There's no one catchment area in our hospitals by and large for all cancer patients. So there have been referral rates that are relatively low, and it can be clinically marginalized, which is unfortunate. And when teams fumble, and teams do fumble because of the lack of coordination or lack of systematic funneling of patients to one area, there are frequent handoffs, and patients get handed off and don't know where to go. They can be handed off to the community, and if there's no communication between that community service and the actual oncology treatment team, it's a problem. Then the community workers don't have access to sufficient information to really be able to implement a comprehensive rehab program. There are still multiple specialists and medically complex cases, as mentioned. So the reality check is that patients truly need help. They're asking for this help, and some of the patient support networks have been, again, some of the push that has been needed in order to develop greater volumes of cancer rehabilitation services, because care silos have been developed. For example, again, the care silos for breast cancer patients. And we even had a care silo created for young adults with cancer, who young adults can be within any disease entity, as we know now. It's not just young adults with breast cancer or young adults with sarcoma or CNS tumors. It's young adults with GI cancers and with a whole realm of hematological cancers. And yet they were pigeonholed, I would say, into this care silo, which was primarily breast cancer, and that's wrong for this group in particular. And the usual care, as mentioned, can be uncoordinated. So patients are distressed. They're asking for this help, and we know we have a great deal to offer them. There are multiple independent care settings. So as general physio graduates, if you wish, those with baseline education, those that come in as entry level to the profession, we can say that cancer patients will be seen in all these areas. They'll be seen in inpatient settings, your inpatient settings. They'll be seen in outpatient services within hospitals. Within rehab centers, you will see some patients with sarcoma, amputation, CNS tumors. So some of the rehab centers have also become more specialized or are seeing greater numbers of cancer patients, et cetera, et cetera. So we really are dealing with all independent care settings that physiotherapists work in. So the career pathways and education in oncology we have seen is quite diverse in Canada. We as an oncology division decided to do some surveys just of our membership in itself to see where are they receiving their education. Is this at a university level or is this primarily within the community? And it was quite a surprise to find out how low this level of education is. So the career pathways are multiple. If you wish to specialize within cancer rehabilitation, you can certainly move on to advanced practice and expert practice. But we can say very clearly now that physiotherapists in general practice now, because of the prevalence in cancer being 1 in 2 patients, or 1 in 2 Canadians having cancer diagnosed in their lifetime, we can say that in our general practices, in outpatients, in sports medicine, in orthopedics, in work-related injuries, that many of these patients will have had a history of cancer. And so in general practice, we need some baseline information and education. And certainly career pathways can be more specialized practice, either working with patients who have lymphedema, CNS tumors, or other types of specialty areas. There's specialized practice. Then there's advanced, where one becomes more of a researcher and clinician within that advanced or expert practice. So that there is a continuum really of education that's needed related to this. Entry level to practice types of competencies, and then we move on to more enhanced clinical practice. Again, I come back to the large realm of cancer. I mean, we cannot underestimate this new language, this new disease, on how it impacts all systems. And as a result, again, it's just not good enough to get an introduction to cancer within oftentimes other courses, cardiovascular disease, and suddenly there's one lecture on introduction to cancer. It's just not good enough. We really feel that this comprehensive knowledge of the disease and how it impacts all systems is very important. So for entry level, enhanced clinical, advanced clinical practice, and then moving on to expert practice and specialization. So what I'm going to review now is some of the types of competencies that we have identified as being needed at these different levels. So for entry-level PT, I think at minimum, the PTs need to recognize and understand the unique rehab needs related to cancer, if nothing else. Knowing cancer pathology and medical treatment interventions. Without knowing that, knowing the stages of disease, it's very difficult to intervene. We just had a national grand rounds in orthopedics for our orthopedic specialists in Canada, or from our orthopedic division in Canada. And it was an eye-opener for me to be on a panel with orthopedic specialists, the teachers, the people who are head of the examination board. And we were dealing with the case study that was presented was one on breast cancer. And it opened my eyes to how much they do not know about cancer as a disease entity in itself. The one great question that was never asked of the patient in the case was, what was the stage of disease at the time of diagnosis? How many lymph nodes were involved? What was resected? What was the stage of treatment? None of these key cases. Instead, the orthopedic specialists are accustomed to treating what they see. But treating what you see is just not good enough when it comes to the realm of cancer. So we need to understand pathology and treatment interventions, staging, the effects of surgery, chemo, and radiation protocols on function, generalized alterations in hematological and metabolic status of patient when they're being treated, the disease and treatment-related weaknesses, cachexia, myopathies, acute pain, chronic pain, and cancer fatigue. So these are the key elements, I think, that need to be covered within an entry-level PT. And again, general practice competencies based on the effects of this cancer and treatment would be to be able to derive an assessment plan, know specific testing protocols and outcome measures related to cancer, using a framework for decision making on treatment options. So know that at minimum, and be able to choose appropriate treatment modalities or exercise interventions for these patients. So in general, we just need indications, contraindications for all of the skills that we've learned in our physiotherapy practice. That's the part that we don't know. What are the indications for all of these skills? When I teach cancer rehabilitation, I'm not teaching new skills. What I'm teaching is the adaptation of the skills that you have learned through your 2, 3, 4 years of study, and how you apply it to this large realm of cancer and all of the types of physical disabilities that are associated with it. So again, this general practice is in all the settings that we've recognized, all settings. So all of you need this general practice core education, entry-level education. But then if you wish to specialize, so those of you who say, listen, I feel I need more information still to treat with adequate information. And so we'd like to know more about exercise benefits and prescription. What are bone metastases? How do we manage patients with bone metastases? Because many of the most common cancers, breast cancer, prostate cancer, will at some point in the trajectory of the disease develop bone metastases. So we need to know how to manage that. Radiation fibrosis, I think, has been under-recognized as a source of some of the chronic pain that patients are experiencing long-term. We call it subclinical radiation fibrosis, which doesn't only impact the region of the breast, for example, in breast cancer, but it impacts GI cancers. It impacts patients who have had radiation for prostate cancers. It may be the source of their low back pain on a constant basis. So radiation fibrosis, we need that information. Treatment of chemo-induced peripheral neuropathies, safety considerations, many post-chemotherapy because of the cardiac toxicities, the cardiotoxicities related to many chemotherapies, and other toxicities. So we need to know about what are the safety considerations. Introduction to lymphedema and return to work. Lots of additional competencies can be added at that secondary level of education. And neurological function should, in my perspective, be included at that enhanced practice competency level, where we learn about nerve palsies, brachial plexopathies, CNS tumors, brain and spinal cord metastasis, spinal cord compression, balance dysfunction, long-term falls and gait abnormalities. And then, of course, we need to start learning about the different cancers. Again, I said this is a large area of study. We need to know the specifics of breast cancer treatment and impact of those treatments, lung cancer treatments, prostate, hematological, gastrointestinal cancers, and what are the treatment protocols, short and long-term side effects. So again, enhanced clinical practice can be applied in all of these care settings. So any of you who might ultimately wish to work in a private practice setting, or in rehabilitation centers, or in outpatient services or inpatient services, this knowledge base is going to serve you throughout those practice settings, and in particular in home care. We have a large network of physiotherapists in Canada working in home care because of the large percentage of our country that is rural and away from the specialized cancer centers. So this home care is an important element, and I would venture to say that anyone that's working in home care truly needs to have a good background at the level of enhanced clinical practice if they're going to be working in home care with patients who may have had treatment for cancer. And then we have specialization. So in Canada, there is a specialization process, which I will go through in a minute. And that specialization is primarily directed to, or the locations of practice are hospital-based clinic or rehab centers or palliative care centers. But that involves patients with more involved reconstructive types of surgery, head and neck cancers, sarcoma, advanced cancers, bone metastasis clinics, palliative care, etc., and lymphedema or lymphatic drainage. These are highly specialized skills. So once you've done some baseline core education, enhanced clinical practice, now I think students and PTs are ready to go into a realm of specialization. I do think that it's a disservice to only go into one area of specialization to you and to the patient if your one area of specialization is simply lymphatic drainage. And unfortunately, we see this in Canada, that many of our physiotherapists consider themselves to be oncology specialized. They are, but if they are only doing lymphatic drainage. And I sincerely believe that everyone has to have that wide scope of perspective on everything there is to know about cancer, and not just lymphedema secondary to breast cancer or some of the GI cancers or other, and head and neck cancers. So again, it's just my perspective. I love specialization. I do think that specialization is certainly needed, higher education at all of these levels. So we come back to expert practice, and this was something that Jackie asked me to include, because this is where, and it's been interesting how things have evolved in Canada because of the need for research and because of the need for educators. We've almost started the cart before the horse. In other words, we've had to move back and say, who's going to teach this? And so we needed to develop those experts, and those experts have become involved in the research. And that research now is serving as a basis for the education that needs to be developed. So we've gone full cycle, if you wish. We've said there's a need for cancer rehabilitation. And when I first began teaching in the year 2000 in cancer rehabilitation, I had very little in the way of practice guidelines to base my teaching on. It was primarily clinical experience and my findings on examination and how I felt I could improve patients. And now we finally have all of this amazing information on research that is and guidelines supporting our practice. And the types of research we have seen developed in Canada, I'll go through in a minute, but it's in exercise oncology, advanced cancers and palliative care, lymphedema, cardiovascular effects of treatment itself. So we have a clinical specialization process in Canada, but we can unfortunately say, I know that this process has really been developed in the United States under Jackie's large leadership, I know, and many others that have worked with her on this specialization process. And I can say we envy the system that they've developed because they've been very systematic in what they've put in place in order for physiotherapists to be able to go through this specialization process. Ours is largely, and we need it for peer review, for recognition within the medical profession, for enhanced patient care, for the credibility. Unless we're specialized, we will not gain the credibility that we need with the medical practitioners with whom we're working. And we need to be accountable for what skills we have and what we're providing to patients, and it benchmarks our skills likewise. So in Canada, what we have to do, and it's largely a self-study process, is that we have to demonstrate that we have advanced clinical competency, and we can provide professional leadership once we've been specialized and prove that we've been involved in professional development activities and definitely involved in research. So to become a specialist in Canada is a long road, and we'll show you what the road is. There is a certification board within Canada, so you have to have had a minimum of 5 years of clinical practice within the realm of at least full-time clinical practice, not entirely specialized in oncology, but a minimum of 300 hours per year in oncology. And you had to have had, of course, a license to practice. requirements are that you develop and are involved in research as well, and that you complete this multi-source feedback questionnaire. It's unfortunately still largely a self-directed study process, and this is where we as educators are now trying to intervene so that we can develop more specialists, so we can help mentor them through this process. And we have to present 3 clinical case presentations, which sounds very simple, and reviewed by 3 expert panelists, and there's a 3-year limit to completion. So if we look at our survey, however, so this is what system we have in place. We believe that there is a level system that needs to be respected. Ideally, we have a specialization process, but without question, there are significant gaps that we've identified. So our division conducted a survey of 15 university programs in Canada relatively recently, and only 3 universities we've discovered are covering cancer rehab in the elective stream. So it's not part of the core curriculum. They're elective courses, and generally between 2 and 3 credits per course. And in those courses, within those 3 universities, they're covering what we consider to be entry level to practice types of competencies, and covering some of the competencies needed to practice at a slightly more enhanced level of cancer rehabilitation. But the hours ranged between 15 and 45 hours, and most of the universities within that, I'd say 12 of the universities are covering primarily breast cancer as opposed to all types of cancer. And I'd say that currently the movement has been towards including a little bit of oncology in all of the different realms of study. In other words, in cardiovascular disease, well, they may have 1 lecture on oncology. In studying neurological or CNS tumors, or in neurology, they may have 1 lecture that covers the potential for patients having had a CNS tumor. I'm sorry, but it's just not good enough, because again, that general understanding of cancer in itself is not there as a background to these students. So when we looked at, again, what are the sources of education for our membership, only 25%, and you can see this, it's reflected in the educational programs that we have available, received their education as part of entry to practice at a university level. And of the 25%, 20% were elective, 60% were core course, which is nice to see, but it was core course dispersed amongst various different disciplines. The majority were between 0 to 3 hours, very low, and the hours of instruction varied tremendously. So 1 to 5, 1 to 30, 1 to 160 hours only in 1 program. And when we looked at, again, more in depth at where is our membership working and how are they becoming educated, we found that there were very few student placements specific to oncology in the majority of cases. And postgraduate courses were the primary source. So these online courses or courses specialized in lymphedema, this is why so many physios have gone into or in exercise training. We can say that the majority of them have gone to those sources because they are the most common forms of education given to physiotherapists at present. So the variety of courses have been a variety in the past, online, face-to-face, and a combination certainly more recently. And the content has been exercise, breast cancer, and lymphedema. So then again, we're looking at what has our membership received, and we're seeing that there's great need for greater education, great variability in the total of hours, and the sources they have gone to the American Physical Therapy Association, become members, and have had education through that source. They've certainly had education in lymphedema, the Ontario Physio Association, and through some of the courses I've offered via the Canadian Physio Association in different provinces. So the courses in order of emphasis that have been there have been musculoskeletal impact of cancer primarily, lymphedema, pain, bone health, palliative care, but very limited coverage. We come back to cardiorespiratory impact of cancer and its treatment, neurological, pediatrics, not well covered, pelvic health, and workplace function. So return to work, very poorly covered in education in general. So some of the non-division community-based courses that are out there, again, most are not certified by any certification body, but there are courses that are being offered, and these are advanced rehab techniques for breast cancer, CIPN in the pediatric population, so the chemo-induced peripheral neuropathy, specifically to pediatrics, is another course being offered in Canada, head and neck lymphedema, exercise training, oncology and pelvic floor, and oncology for fitness professionals. So we can see, again, there appears to be many gaps. But there is good research occurring in Canada, and I'm happy to say this, that these research are now part of our national education. Every one of them is part of our national education team, and the group that we're working towards to develop the clinical mentorship that's needed. UBC, Dr. Kristen Campbell has developed bone metastasis guidelines along with an international group, and these are about to be published. Cardiovascular effects of treatment is her specialty. She has a cardiovascular lab that tests primarily patients with cancer. We have Margaret McNeely doing a great deal with general cancer rehabilitation, lymphedema, knowledge translation, etc., etc. University of Saskatchewan has had some research done on neuropathies. Queen's University, Colleen Dunphy is looking finally at the competency profiles for cancer rehab and breast cancer with Dr. Jenna Smith-Turchin. Shirin Shalwani, someone who has worked with me extensively, is doing work in cancer and advanced cancer and exercise intervention, etc., etc. So we have, at least at minimum, we have some experts growing in Canada, but there are gaps still. And the gaps are these progressive competency profiles, which hopefully this has been the focus of our oncology division, and hopefully will become and has become a new preoccupation, a new important, I think the importance placed on this education is there with the WCPT as well, and the oncology division that we have. And there's where I'm so happy that students are interested in the development of these competencies. So we've got our competency profiles that we're hoping to develop in concert with the World Confederation of PTs. There are guideline developments ongoing, multiple works in process presently, and we need more. We need a growing number of professors. That is our biggest drawback presently. There are very few of us, as you can see, that are specializing in oncology. And so we need clinical placements, clinical mentorship, fellowships, and research fellowships for certain. And in general, we just need to be able to empower physios, empower the students, empower graduates within the program to be able to engage with patients and to realize how much they can enhance their quality of life, and quality of survivorship is what I always speak of. It's not just the capacity to survive your cancer, but to be able to live well with that cancer, and to enable, we need to be able to enable PTs to develop within this realm of specialization, which is going to become more important as we go on in time. So I'd like to thank you all for your attention, and now we'll move on, and I'll just try to close this if I can.
Thank you so much, Marianne. The presentation was so educational. Thank you very much. I'm just going to open the floor up to 10 minutes of questions. So either if you can raise your hand or just post in the chat, that would be great.
Hi, Marianne. So I see that David has a question he posted in the chat. So he said that you, Marianne, have highlighted the lack of education that pre-registration students receive around oncology, which he certainly experiences, and he has had no lectures on oncology. So he wants to know, where can we go to educate ourselves on the knowledge that you suggest we need as entry-level PTs? You mentioned courses, but sometimes these can be difficult and or expensive to access.
As it is at present, there are a number of online resources. I mean, I don't want to be self-promoting, but we're just developing this type of online resource because of COVID. All of the course material that I've developed, for example, is presently online, and it's subdivided between a level, entry level to practice, and then your enhanced, and then more specialized practice. So there are other resources that are available online. The problem still has been the actual accreditation of this online education. But I would say that by and large, the APTA also offers some great online resources. And there are, once we begin to be able to do more face-to-face courses, we're going to recommence in Canada doing these face-to-face courses. And I've done some internationally as well, where we can actually interact with students at a particular level. I think that the possibilities now, given the lack of educators at various university levels, I believe that the way to go now is to invite the specialists to the different universities and perhaps just do a weekend course, something of that basis, which would give students that entry level of competency at minimum. Because if we were to wait until the experts get into the university and get their professorships, etc., we may be well behind in the level of education needed. So I would say that if you were to do a search online, you will probably find that there's more than you believe in this entry level to practice type of education. We're offering them through KCS, which is a knowledge, key clinical skills, and through BF Formation, which is all entirely translated. And that was why I work with that particular group, because everything that we've done has been translated into both French and English.
Okay, David said, thank you so much. It did answer it.
Good.
Okay, does any, and also, Janie, do you want to take this next question?
Yeah, of course. So we have another question for you, Marianne, which says, what is the role of oncology in seeking out or initiating oncology physiotherapy?
A great question, a very good question. And I think that now our role really is to sensitize the medical professionals. And when we started our cancer rehabilitation service, I was brought in to oncology as a consultant, basically, to say what can be done here. The oncologists were getting information on the value of exercise, and just as a reflexive reaction, referring patients to community services, which were not specialized. And so the greatest role that we have to play now is to educate the oncologists. I believe all disciplines within oncology, the medical oncologist, the surgical, and the radio oncologist, as to the value of what we have to offer, and sensitize them to some of the guidelines that have been developed, for example, on bone metastasis, and guidelines for exercise prescription, guidelines for management in palliative care. And we need to educate the medical professionals without question. And if we were entering within a service or in a rural area where no service has been developed, the most important element of what we have to offer now is education. I go first and foremost with a large binder full of references and sit with those medical professionals and do rounds with them and for them. So educate them. And until they see the value within, or see that there is actual research that has been done within this realm of cancer rehab, we're not going to have the recognition that we need, nor will there be systematic screening, which is the baseline of what we need to develop, systematic screening.
Great, thank you. And we actually have Joanna with her hand up, if you would like to speak your question.
Sure, thank you so much for the talk, Marianne. Funding seems to definitely be a barrier just in rehabilitation as a whole. And you've done a great job of kind of explaining those gaps with rehabilitation and oncology. Is there any resources that we can source out to our clients or our patients in terms of funding and rehabilitation that you're aware of?
I think that's a really, really good point. That has in large part been why some of these services haven't developed. Even the service that we developed, the Cancer Nutrition Rehabilitation Program, was funded entirely by donations. It was funded by foundations that gave us some funds in order to be able to develop these clinical services and the research that developed as a result. And within our physiotherapy departments, our program spanned all of the McGill affiliated hospitals. And within those physiotherapy departments, likewise, funding was never dedicated towards oncology services. They had PTs working, sometimes up to 25 and 30 PTs working in everything but oncology. Yes, they were seeing incidentally oncology patients, but there was no specific funding to have oncology specialists work with the patients. And once again, within that network, we were working with Hope and Cope, because Hope and Cope raised the funds necessary for us to be able to hire a large team of physical therapists to screen patients. I felt the primary goal of our program was to screen patients and at minimum be able to identify their rehab needs to the medical, surgical, and radio-oncologists. And that began a great demand. Prior to that, they had no idea what the patients needed, and we were communicating within their files. In other words, we had shared electronic files, and all of our physiotherapists had to enter in detail their assessment findings, because that was what spurred the oncologists to realize, my goodness, this patient has developed peripheral neuropathy. They're losing their balance. They can't walk more than 5 minutes. I think that in itself was invaluable, but the funding barriers are huge. We have received funding primarily through breast cancer foundations, prostate cancer foundations, hematological cancer foundations. So we've had to go to the various foundations that have raised funds for patient services, and some of these foundations have allowed us to develop clinical programs. And I would say that is one source. It certainly has been a source of our research funding as well. Our Quebec Breast Cancer Foundation largely funded our research on bone metastasis and skeletal fragility in breast cancer. And they were very general. The Cure Foundation funded that as well. I would say that there are quite a number of foundations that are reasonably wealthy, and they're looking for the development of clinical services to patients. So that is one source for certain for research and for even some of the clinical service developments. But by and large, our PT departments within hospitals have to recognize the importance of this and start devoting staff directly to these services. That's what's not happening in Canada as of yet.
Your presentation is amazing. It touched on so many important factors, and I just want to add to what you're saying about funding. We just had a paper accepted from the Specialty Council that writes the specialization exam in oncology, and we surveyed our new clinical oncologists, and we've only had 3 exams, so we only have 3 years of people. There were only 2 years of people about the paper, but we're finding that the advanced practitioners are now advocating for these things. And one of the things that came out in the paper is that we need to get on funding boards. We need to get on policy boards so that we are included in, the healthcare policies and funding for these things. Just only within the last year, Marianne, who's a physical therapist here in the United States, she's been sitting on a board that, it describes cancer rehabilitation nationally. And the nurses and the physicians were the ones who decided who gets physical therapy. And she was pretty dogged. She sat like a pit bull on this board and said she's not leaving until physical therapists are actually on this policy, that they are directly related to us, referred to us, so we decide who gets the care. So even though we're specifically looking at students today and development, I think you have to look at the long term and get on some of these funding boards or some of these policy making boards nationally in your countries so that we are recognized. And again, we're the PTs that need to educate other people. They're not going to give us anything. It's up to us to let them know what we can do. And I'll close out here. Thank you.
So important what you're saying, Jackie. I don't know whether you hear me. So important what you're saying, because I agree with you 100%. And I think that we have in certain realms, certainly at the level of McGill as an example, I went to the Department of Oncology and I said, what are your oncologists learning about what the value of cancer rehabilitation could be? Can we start fellowships where our specialized physical therapists can begin to work with your oncology teams, because that's what's needed. We need to educate you as to what we can do. And certainly the patients already recognize the value of what we're offering, but that hopefully will open the doors, as it is presently. When we did that within the programs that we developed, head and neck cancers, for example, and lymphedema, they screamed blue murder when the services were cut because there weren't adequate donations left to fund the physiotherapists working with them. And they then began to raise their own funds in order to support the services that they now felt were needed. So it was a bit of a cart before the horse once again. We're going in and we're saying this is needed, show them what's needed, and then the demand will be developed. And I 100% agree with you. That's the work that really needs to be done right now.
Yes, thank you. And multidisciplinary teams was one of the big ones too, that we educate these multidisciplinary teams. And that's the only way we're going to really make some significant inroads. Thank you. Looks like Janine has her hand up.
Yes,
yes it is. One of the problems we see in the Netherlands is on guidelines, that our guidelines are evidence-based guidelines and are rated with the grade system. And physical therapy is rated, is downgraded a lot, the studies. And therefore, for us, it's difficult to get rehabilitation in guidelines, because they say there is no evidence. And that's something that's very difficult. I don't know if it's especially for the Netherlands or in other countries as well. We all see the benefits for our patients of rehab, and because of the grade, the position of the physical therapist is downgraded in our guidelines.
That's a very good point, Janine. I don't know whether you hear me. A very good point, because McGill Oncology, they consider themselves to be a very prestigious organization. And so it was always banging on the door of the head of oncology to convince them that we had sufficient information and sufficient background in order to be able to provide evidence-based services. But they now recognize, because in doing some research with them, that this research is not easy to do. That's why most of the research has been done primarily in breast cancer, because that's where the population is, right? So for me to do studies with patients with multiple myeloma, I need a large network of hospitals in order to be able to get an adequate population of patients to study. And there are variances between their hospitals and to how they manage treatment as well. So the variances here don't facilitate our problem. And not only do we see a large realm of cancers, for us to be able to catch up and develop guidelines in every element of cancer rehabilitation will take us 1,000 years. So I'm not, I think we have to, through what guidelines, and I'm very happy to say there are now guidelines for multiple myeloma that have been developed in Canada for exercise and bone metastasis, certainly for lymphedema management, and now there are guidelines being developed for in rehab for advanced cancer patients. Once we catch up with these guidelines, hopefully the powers that be within these prestigious universities will better recognize what we're doing. I often turn around, I'm sorry, I shouldn't say this perhaps, but turn around and say, all right, and do you have evidence for everything that you do in your clinical practice? Right? Everything that you do. You tell me what the evidence is, because I will turn the tables on you. And I think that, you know, that's just the unfortunate thing that is occurring for us, because we're newcomers to the block and everybody is emphasizing these guidelines and sufficient research and everything else.
When I started discussing the problems with when we developed a new guideline for patients with breast cancer, the radiotherapists weren't aware of the problems they were causing, because they only see their patients 2 to 4 months after the radiation, and then the problems begin.
Yes.
So I said, well, you have a lot. It was 2012, and all evidence was from before 2000. So I said, there's a lot of new evidence. Please read it and use it in the guideline.
Yes.
And the next time they said, oh, I'm really impressed about what the problems are. So yeah, that was good. But in general, it's rather difficult to get physical therapy within the guidelines.
Yeah, I agree. One of the things we also have done, Janine, is that in any of the research that we did, we certainly involved the physicians. So I had the radio oncologist working with us on looking at subclinical radiation fibrosis in young breast cancer patients, because it was to convince them in the first place. And so they saw the difficulty it was, even with a very limited population, to recruit patients for this work, and then to intervene, and then to have patients comply with what we're offering, because they're so overwhelmed with treatment, right? If we're trying to do this during their actual process of being treated for their cancer, they're looking at us like a snake with two heads and saying, I have no time for this. My life is on hold as it is. So I think that engaging the physicians in our research, engaging the experts that are there already, we're not teaching new skills. We're just saying, so how does your incredible cardiovascular disease skill apply to cancer? Let's learn more about the cardiotoxicities of cancer. And I think we may accelerate some of the research being done if we can do that.
Thank you so much. And we're just going to bring this Q&A, this discussion to an end just now, so that we can have Janine's presentation, if that's okay.
Perfect.
Thank you so much.
I have the honor of introducing Dr. Janine Hidding. She's a senior lecturer in Master Oncological Physical Therapy at Avans and Breda. I'm sorry in advance if I pronounced that wrongly, in the Netherlands. And she's presently a chairperson at the client board of Sensir, which is an elderly care organization. Her PhD is focused on the impact of medical treatment on physical functioning, with emphasis on lymphedema. She's had 40 years of experience as a physiotherapist and has an interest in education and research on rehabilitation medicine, physiotherapy, and allied health science, with special focus on cancer and lymphedema. So yeah, welcome, Janine. Please take the mic.
Thank you for the introduction. My presentation is about oncologic rehabilitation in the Netherlands. What I would like to do is tell a little bit about our education on oncology. The physical therapist in the Netherlands is a bachelor level, not a master level. So that's a difference with a lot of other countries. And in the bachelor education, you have only a few institutions that educate on cancer. So many of the general practitioners don't know anything about cancer rehabilitation, but they see their patients, of course, and a lot of times they treat patients with cancer as well. And for us, it's important, and that's for our professional organization as well, that patients get a good treatment and will be treated by well-educated physical therapists. We see different levels of education on oncology. It's post-bachelor and it's on master level. I am a lecturer in the master education, and post-bachelor you can do short courses on different parts of oncology rehabilitation. Guidelines are very important for us. I already told a little bit about that. For us in the master education, the guideline on rehabilitation of patients with cancer is one of the most important. Cancer rehabilitation is offered in hospitals and in rehabilitation centers. And we have in the Netherlands 3 centers with multidisciplinary treatment that rely on that rehabilitation guideline as well. Moreover, we have a lot of guidelines on tumor types, and only a few of them have a part on physical therapy. And there's the most evidence on breast cancer. That's my specialty as well. Moreover, we have a lot of guidelines on palliative care. It's on fatigue, it's on pain, it's in general end of life. And in that guidelines, physical therapy has a part, but there's a lack of evidence. A few years ago, our professional organization felt the need to make a difference in treatment of patients with cancer. And there is a lot of, when you look at the needs for rehabilitation of patients, you can look at the chronic care model. And that model states that about 70% of the patients have limited needs and can be supported by self-care in general. 25% of the patients need rehabilitations and suffer from late effects that require specialized care. I think it's more than 25%, but we have to prove that it is really more. And 5% of the patients have highly complex needs for rehabilitations, and that 5% should be referred to specialized rehabilitation centers. And the 25% of the patients with need of rehabilitation can be offered rehabilitation at primary practice. As a lot of our physical therapists have very little knowledge about oncology, we made 4 levels or 5 levels of complexity of health problems of patients with cancer. And based on that needs, we made a diagram where patients should be treated. Level 1 is a simple problem which can be treated by, and the patient has self-efficacy, so it's simple to treat. Level 1 is a general problem, 2 is a problem related to oncology, 3 patient has 2 problems, and level 4 there's a multiple complex problem. When you look at this scheme, patients with level 1 and 0 can be treated by general practices without a lot of knowledge on oncology. For level 2 and 3, some knowledge and skills in oncology are required. So that is what a bachelor with some courses in oncology could treat. And for level 4, you need special competencies in oncology, and that's what Marianne told as well. And therefore, you really need a master level. What we do in our master levels is that we educate in especially how to use your skills as a general practitioner in oncology. And we use a lot of cases in our education. Our students have to practice at least 8 hours a week with patients with cancer, and they have to make case reports. And in the 3rd year, they do a project and write a thesis about an oncologic problem. For me, the specialized oncologic physical therapist has to think about multidisciplinary treatment. Our patients always, as Marianne already said, have a lot of problems. Because of the treatments or before the treatment, there was already a problem with lifestyle. Because of the treatment, patients have problems with diet, or because they are training a lot, they need a special diet with they need psychological support, because although a lot of patients survive their cancer and cancer treatment, a lot of them will go on to palliative treatment, and that is that has influence on how on the emotional status of the patients. We use occupational therapy in fatigue, for example, because they have other skills than we have as physical therapists, and when we treat patients together, it's easier to get the patients there where he wants to be. For us, it's always important that the question of the patients in where he wants to be treated is the starting point for our treatment. And then in discussion with the patients, we look at what the patient can, what we can do for a patient and who has the best skills to treat that patient. And lymphedema is only a small part of our education, because there are so many other problems. And for us, patients that people that are specialized in lymphedema are not specialized in oncology. And when they want to be specialized in oncology, they have to do special courses. That's what I would like to share with you for the moment.
Thank you so much, Janine. That was a really great presentation. Again, I'm just going to open the floor up to any questions for Janine, either in the chat or just on the mic. Thank you.
Hi, Jackie. You could go ahead.
Thank you. Thank you. I have a question for Janine. How is there any link between the physiotherapy practices and students? Like, are you going in and giving lectures at universities, or can students do like a clinical rotation with you?
Our students do a clinical rotation within each other or with specialized physical therapists.
Okay. All right. So it's really self-directed, that a student needs to identify that they're interested in these areas, and then they can go on to get education, right?
Yeah.
Okay. I'm not as familiar with the clinical work in the Netherlands, but I am a good friend and colleague with Caroline Speckschneider at Maastricht University. And I know there's a lot of research coming out of the Netherlands. Caroline's specialization is head and neck cancer, which again, according to Marianne's scheme, she would be in an expert practice area. Are you doing lymphedema research, or are you familiar with people there who are doing research into lymphedema?
A part of my thesis was lymphedema.
Mm-hmm.
And yeah, well, one of the problems we were discussing a lot was about measurement instruments. So I did research on, I did a systematic review on measurement instruments on lymphedema. And as part as research on patients receiving chemotherapy, the TAC course, the Dalzell course, we did measurements on lymphedema as well. So that's part of my thesis. So that's what I did during my thesis, and now I'm doing research with the students. And in our department, lymphedema is not as much, not so much focus. It's more on exercise, on return to work, on pain, fatigue. And the general measurement instruments we use in physical therapy, how can you use them in oncology physical therapy?
Okay, can you tell us what your results were from the lymphedema perspective for measurement?
There are a lot of measurement instruments, and for extremities you can use water displacement, but I think that's very messy. So I like to use a simple tape. And that's very reliable when you do it by yourself every time. The inter reliability is a little bit less, but when you have a good protocol, it's okay. And Nele de Voogd from Belgium, she's very specialized in lymphology as well. She researched a special kind of tape measurement with a bar and tapes on it every 4 centimeters. And that's even more reliable than water displacement.
That's so important. I've published several papers on measurement-focused studies, and like Marianne alluded to, that we need to have this research now to take back to the physicians to show, that we are, proficient and that we have an evidence base, and then that leads to autonomy of practice, where people recognize that we're the ones that do physical therapy, but we also are the ones that need to evaluate patients to determine what level, like you were talking about, Janine and Marianne, that they need to either self-care with a little bit of education, or they need to be seen by a physical therapist, and at what level of therapist. So this is very important.
Yeah. One of the problems we see is that patients are referred at a very late stage. Mm-hmm. And one of my students, she talked with me about that, and then we were thinking about how the nurses said they had only 2 minutes to look at physical problems. Only 2 minutes. So we had to think a lot about what can we do in 2 minutes. In my research, we found that you can measure only at 30 centimeters of the arm from the wrist, instead of the whole arm, and look at the percentage difference between the two arms. So that's a lot easier. We gave them an Excel sheet so they can easy put on their measurements and know if there's anything wrong or not. They have to ask about pain, and with pain more than 4, a patient should be referred. You should ask, are you doing as much as you did before your treatment? If they don't, please go to the physical therapist. And I'm thinking about the last one. The shoulder mobility is an important thing as well in patients with breast cancer, of course. And what we thought about, you just put your hand at your other ear, and when you can't do this and you can't put your elbow to the back, there are really mobility problems, and that's a need to go to the physical therapist as well. So that's very easy, but doing this, they saw that patients were referred more than 100 days earlier to the physical therapist.
Yeah, that's so important. One of the really early papers that I had written with Pamela Vangie from the United States on shoulder function, and we were trying to determine what the disability rates were. And most of the disability was determined by surveys that the physicians had sent out, or telephone calls, and they're just asking, do you have a problem? And, they're not asking the question accurately, like, can you dress yourself? Can you feed yourself? Do you have pain? So these measures are so important, and it's come a long way. I mean, this was probably 15 years ago that we published this paper.
I know.
So it's good to hear things are moving along. Marianne has her hand up.
Yes. I'm enjoying this conversation. And I would say that in my practice, because we weren't only seeing breast cancer patients, but all of the above, I found the most important type of research that we did was that using the physician's terminology. In other words, they're talking about ECOG performance status. The first piece of research that we did in a lung cancer population, advanced lung cancer, was to show them how off base they were with their estimates of patients' performance status. So I had to use their language to say, listen, you're telling me that this person is a 0, meaning that they could tolerate any treatment you have out there. And I'm telling you that this same person cannot stand up from a chair more than twice. So there's a mismatch between your perception of someone who may have walked into your office and the reality. And I think that in part we're very good. We navel gaze a little bit because we're so specialized in our rehab skills, right? We talk about our lovely outcome measures and this. They know nothing about any of these outcome measures, and that's not their language. I do think that we have to take those tools that we have and show them that perhaps our DASH relates, or DASH outcomes relate to a performance status that's a 2, not a 0. I think we have to start correlating some of this, and that's been the only way we've been able to convince them of the need. And I love, Janine, your classification of PT skills according to the needs of patients. I do love that. I think, we always talk, again, navel gaze and talk about the level of education that the PT needs, but it wasn't necessarily related to the level of needs of the patients themselves. I like that.
Thank you. Yeah, we educated the radio therapists in the eastern part of the Netherlands with my research. So one of the radiotherapists always asks, well, do this movement. She adopted very well.
We actually, what we did, we used some very simple tools clinically. We just said, look at, just give me a heart rate monitor and a simple chair rise test, and I will tell you how well your patients are doing cardiovascularly. I don't have room to do a 6-minute walk test in the hospital corridors when there are gurneys and other elsewhere. Let me do some simple tests within this office, and I will show you how off base you are with respect to the performance status of patients. Yeah. So good, and like you say, and they would come around and raise their arm and say, so am I doing okay today? They would but in effect, we were telling them things that are so self-evident to us, but not to them.
Yeah, it's true.
We just have another question in the chat. I think that last discussion sort of started answering it, but I'll read it out. It says, can you suggest a source for simple screening tools to provide to healthcare professionals to ensure patients who need physiotherapy get to us? A simple way to see their needs?
We had, I will answer quickly just what we used and on our general population of cancer patients. And there were simple screening tools that we used. And some were outcome measures that are for breast cancer patients, DASH outcome measures, and some of the others quality of life screening tools. But as a clinical screening tool, I still found the best screening tools were the simple physical function tests, grip dynamometry, chair rise and heart rate evaluation, recovery following that chair rise. So sit to stand, which has baseline numbers. And I felt that we had, or a 2-minute walk, very, very simple physical screening tools, physical task screening tools were the best thing to use to say that patients were in need. It didn't take very much to do so.
Hi, I just want to give a plug for the research journal Rehabilitation Oncology. It's part of the APTA Oncology Academy, and maybe Eric can post a link if he doesn't mind. He's our webmaster for IPT-HOPE. If you could post, Eric, could you post a link in the chat line? Within Rehabilitation Oncology, there are several evidence-based articles called EDGE task forces. So that's EDGE task force. And groups of physical therapists, expert physical therapists have gone through and done evaluations of some of the common tools used in cancer rehabilitation for pain and lymphedema and cardiorespiratory fitness. And people can look at those tools and get evidence-based tools and methods to use them. And then not only can you use them, but like Marianne and Janine are talking about, you can show these to physicians to show that we have some evidence if they're interested in, how we decide to use our tools. And Eric has posted that online. So for those of you that want to look for evidence-based tools in oncology rehab, there is a source, and it does get updated as new tools come about. So I just wanted to contribute that. So I'm going to turn this back over to my students.
No, thank you. Thank you for that, Jackie. And thank you again, Janine and Marianne, for your presentations. That brings us to the end of the Q&A for you, Janine. Thank you so much. And I think, Jackie, you just have a few conclusive sentences for the session.
Yes, thank you so much. This was just amazing, to be able to be starting a student networking session and to have Dr. Janine Hitting and Dr. Marianne Dalzell here. This just was like a wonderful way to begin this, because they're experts international in these areas. Nana Chagbo, sadly, she's not here today, but she's from Nigeria and she's our educational lead, and she will be sending Marianne and Janine our International Scholar Award in recognition for this presentation. Okay. And oh, you're welcome. Thank you so much. It's so little that we can do. And also, we would like to begin an International Student Scholar Award. So it's going to be shared between our students who were with us today. And I wanted to thank all of the students for all their work and for hosting this and helping us when things went a little wrong. So Katrina, Janie, Jenica, Sophia, and Elizabeth, you're going to be the original recipients of the International Student Scholar Award. Thank you so much, everyone. Any closing words from anyone?
Yeah, I just want to say thank you both so much, Marianne and Janine, for your presentations. Coming from like a student perspective, it was so well put together, and it you guys did the presentations in a way that it was easy for us as students to understand and interpret based on the limited knowledge that we do have. So it was just so interesting to see the different aspects of it, and just to explore the different avenues of research and doing things, and the different scopes of practices that physiotherapy has, and different treatment options and things like that. So from a student perspective, I learned so much, and I think I can say it for everybody, for Liz and Janine and Katrina and Sophie, we just had a great time and it was so good working with you guys. So thank you so much.
Thank you.
Just quickly, we're also talking about a social media site that we want to have on our IPT-HOPE website for students. So we'll let people know when that comes about, but this way students can communicate with each other internationally. And then because of the work of these students here, we're hoping to host this at least, annually. So this is just a wonderful opportunity to, welcome and bring students into our group. So thank you again, Janine, and thank you, Marianne, for getting this going and sharing your immense, wonderful knowledge and giving this, such a wonderful international perspective. Thank you again.
Thank you, Jackie. I thank you for your leadership. Yes, I truly thank you for your leadership, because it's not easy to work as much as you do, and I know you do, on a volunteer basis for this organization, and you've put your heart and soul into it. But moving now into this realm of student education is gold. And thank you very, very much.
Yeah, thank you again. Okay, so we're going to say good afternoon, good evening.
Good morning.
Yeah, best wishes to everyone.
All right, bye.